Welcome to this deep dive. Our mission today? Well, we're going to explore a really fascinating set of notes covering some key concepts in mental health theory and application.
Exactly. Think of these sources almost like a map, a guide to understanding everything from how anxiety affects us, the brain's chemistry, all the way to therapeutic relationships and, crucially, safety protocols.
Right, we're going to unpack these notes together, try and pull out the most important bits, the key insights, so you can get a really solid handle on this material pretty quickly.
It is a lot to cover, but I think diving in like this gives you a clear picture of the essentials. It's about getting past just definitions, really.
Yeah, understanding the why and how. Okay, let's unpack this. So where these notes start is with anxiety. What it is, how it shows up at different intensities.
And how that intensity actually changes our experience, our perception of the world around us.
Which brings us to this idea of the perceptual field.
Right, basically your awareness of what's going on around you, and anxiety directly impacts that field.
So the notes outline 4 levels. First up is mild anxiety.
And this is often, well, almost positive, right? Your perceptual field is actually heightened.
Sharper senses, more aware. It can boost motivation, help you learn.
Yeah, you're using sort of everyday coping mechanisms here. But then it ramps up to moderate anxiety.
And that's where the shift happens. The perceptual field starts to decrease.
Right. Less alert, concentration slips a bit, problem solving gets harder. But physically.
You might notice more muscle tension, maybe some restlessness.
And this is where the notes say ego defense mechanisms often kick in.
Then we get to severe anxiety.
Yeah.
And here, the impact is really significant.
The perceptual field becomes severely diminished. It's really hard to focus on much beyond the anxiety itself.
Yeah, concentration is basically gone. No real attention span. Simple tasks feel impossible.
And the physical symptoms really pile up. Headaches, palpitations, insomnia, feeling confused, tachycardia, hyperventilation.
Let's call this a psychoneurotic response.
And then the most extreme level, panic anxiety.
This sounds intense.
It is. It's described as potentially a psychotic response. Maybe hallucinations, delusions, extreme withdrawal, inability to communicate.
And the notes stress this is life-threatening.
Absolutely. Often from the sheer physiological stress. The main goal here is just preventing complete emotional exhaustion. And thinking biologically, that neurotransmitter norepinephrine, the fight-or-flight one, is firing on all cylinders here.
Wow. Seeing that progression really shows anxiety isn't just one thing. And you mentioned defense mechanisms earlier, at the moderate level.
Right. The notes give a great list of these ways the mind tries to handle tough emotions, sometimes, totally unconsciously.
They're like mental tools, almost.
Exactly. Unconscious tools to navigate distress. The notes give definitions and examples, which really helps clarify them.
Okay, like sublimation. That's channeling unacceptable actions into acceptable ones.
Yeah. The example is, instead of punching someone when you're furious, you punch a pillow. You redirect the energy safely.
Okay. Then reaction formation. That's concealing an emotion by acting the opposite.
Right. Like the example of the guy who secretly likes a girl but acts like a bully towards her, hiding the true feeling.
Got it. What about suppression?
That one's voluntary. You consciously decide to push thoughts or feelings aside for a bit.
Like the example, I'll worry about losing my job and the bills next week, not right now.
Exactly. Whereas repression is unconscious. You block unpleasant feelings without even realizing it.
Like the person with a fear of the dentist who keeps somehow forgetting their appointment.
Precisely. Then there's regression.
That's the sudden childlike behavior, right?
Yep.
Doesn't fit their age.
That example is a child who starts wetting the bed again after their pet dies, reverting under stress.
Okay, displacement. That sounds like taking it out on someone else.
It is. Shifting your emotions onto a safer target. Like the doctor who's mad about work and yells at a nurse.
Unfair, but a common mechanism. Undoing.
Trying to make up for something you did, the child yelling at their mom, then quickly doing chores to compensate.
Right. And compensation is emphasizing strengths to cover weaknesses.
Yeah, like Gillet, who wasn't sporty but was great at music, so she poured everything into piano practice.
Makes sense. Rationalization is a big one. Justifying bad behavior.
Finding a seemingly logical, acceptable reason for something that isn't really acceptable, like, I shouldn't quit smoking because I don't smoke around my family, it avoids the real issue.
Denial. Pretty straightforward, pretending the truth isn't real.
Yeah, I don't have cancer, the tests are wrong. Just refusing to accept reality to block the anxiety.
Okay, identification. Taking on characteristics of others.
Kind of like assuming traits. The example suggests seeing a child yell and concluding their mother must yell at them, sort of absorbing characteristics.
Interesting. Intellectualization.
That's focusing on the facts, the logic, the practicalities to avoid the emotional hit.
Like the person with a terminal illness focusing only on making a will instead of grieving.
Exactly. Introjection is next. Integrating others' values.
Right.
Taking on the beliefs of others, often parents, as your own. The child saying, don't cheat, it's wrong, because they've internalized that value.
And lastly, projection. Putting your stuff onto someone else.
Accusing someone else of having the thoughts or feelings you actually have. The classic example given is the psychotic patient saying, I'm not crazy, you are.
Wow, that's quite a list. It really shows the creativity of the mind in trying to protect itself, sometimes in unhelpful ways.
It's a fascinating toolkit, and from these psychological strategies, the notes make a big shift over to the biological side of things.
Yeah, brain chemistry, neurotransmitters, how that all ties into mental health and treatment.
Super important stuff. We mentioned norepinephrine already for fight or flight.
Right. The notes also bring up monoamines. They regulate emotion, arousal, and are apparently decreased in depression.
And there's a slightly complex point about MAOIs, the enzymes. High levels of the enzyme cause depression, but MAO inhibitors are used as antidepressants. It's about balance.
Okay, that makes sense. It's delicate. Then there's GABA.
GABA has a calming effect. It slows down nerve signals. The notes explicitly say it's used to treat anxiety.
Acetylcholine is linked with Alzheimer's and also involved in muscle control and memory.
Yeah, and dopamine, a really key one, is noted as being increased in schizophrenia.
The notes also give a quick mention to the limbic system. That's the emotion center, right? Fear, anger, hope.
And neuroendocrinology, which is the link between the brain and the hormone system.
And body rhythms, too, like the circadian rhythm.
Yeah, keeping a regular sleep schedule helps. The notes talk about the melatonin-serotonin balance, darkness versus light, and how disruptions can mess with sleep and mood, potentially leading to depression.
And briefly, the nervous systems. Sympathetic for action.
Decreased digestion, dilated pupils, faster heart rate.
And parasympathetic for calming down.
Increased digestion, slower heart rate, rest and digest. Understanding these helps make sense of anxiety's physical side.
Which leads perfectly into the medications because they often target these exact systems.
Right. First on the list are MAOIs like phenelzine, mood elevators.
But with a huge warning. Avoid foods with tyramine.
Absolutely critical. Aged cheese, alcohol, avocados, mixing them can cause a hypertensive crisis. Also avoid lots of caffeine.
Okay. Then SSRIs like sertraline, paroxetine, common antidepressants.
Yep. Sertraline notes a side effect of sexual dysfunction. Paroxetine or Paxil has a really serious warning.
The suicide risk.
Exactly. Patients must be monitored because initially the drug might give them the energy to act on suicidal thoughts they couldn't act on when deeply depressed.
That's sobering. And a major adverse effect for SSRIs. Never mix with males.
Huge risk. Serotonin syndrome.
Which the notes say is deadly.
It can be. Symptoms include confusion, restlessness, anxiety, muscle rigidity, high blood pressure.
And the treatment?
Stop the drugs immediately. Supportive care, ventilation, muscle relaxants if needed. It's an emergency.
Okay. For anxiety, we have anxiolytics, benzodiazepines, like diazepam.
Right. They enhance GABA's calming effect. They're CNS depressants.
Key warnings. Avoid alcohol risk of respiratory depression.
Yeah, potentially fatal. And avoid driving because they cause ataxia, clumsiness.
And they're highly addictive. Need to be taken very responsibly.
Definitely. Moving to antipsychotics. Clozapine, haloperidol, for things like severe schizophrenia.
Haldol specifically mentioned for severe cases.
Yeah.
But these have major side effects, too.
Oh, yeah. Extrapyramidal symptoms, EPS, movement problems, acute dystonia, those awful muscle spasms.
Laryngospasm can be fatal.
Right.
Treated with anticholinergics.
Yes. Also, tardive dyskinesia, the bizarre face-tongue movements, stiff neck, swallowing difficulty, and pseudoparkinsonism, akathisia, that awful inner restlessness.
And beyond EPS, there's neuroleptic malignant syndrome, NMS.
Also life-threatening, high fever, rigid muscles, sweating, racing heart, autonomic system going haywire.
And specifically for clozapine, a huge risk of agranulocytosis.
Yes, that dangerous drop in white blood cells, neutrophils, makes people incredibly vulnerable to infection. Deadly.
So the nursing focus is intense monitoring, watching for infection, weekly blood tests for months.
Absolutely crucial. And there's that stark note about Haldol.
That a patient on it will lose their right to autonomy.
That's what the notes state. It's a powerful medication with significant implications.
Okay, mood stabilizers. Lithium.
Big focus here is risk of lithium toxicity.
Early signs are muscle twitching, vision changes, nausea, vomiting.
Right, and late signs. Slow heart rate, sedation, and a granulocytosis pops up again here too.
Need to know that normal range, 0.6, 1.2 milli-EQL. What increases toxicity risk?
Dehydration, lots of sweating, low sodium levels, being older, kidney problems. These are all contraindications or risk factors.
Then sedative hypnotics, general CNS depressants.
So risk of CNS depression, they're really just for symptomatic relief.
Highly addictive, need low doses, and safety planning is key.
Definitely. Do not give if someone has organ issues, substance abuse problems, especially alcohol, or is suicidal.
And monitor closely for drowsiness, confusion, lethargy, even aggression or hallucinations.
Right. What about ADHD meds like methylphenidate?
CNS stimulants, so the risk is CNS hyperactivity.
Makes sense. Education for patients and families is vital. Avoid driving if dizzy, avoid coffee, don't stop abruptly.
Avoid OTC drugs, monitor glucose, and watch for signs of that hyperactivity.
Insomnia, no appetite, bounding pulse, tachycardia, hyperventilation, chest pain, even hallucinations or delusions in extreme cases.
Lastly, amitriptyline is mentioned as a TCA, a tricyclic antidepressant for major depressive disorder.
Phew. That section really drives home both the potential benefits and the serious risks of these medications. Careful monitoring is non-negotiable.
Absolutely, but it's not all biology, right? The notes then shift to the human element, the therapeutic relationship and environment.
Crucial. Starting with therapeutic communication techniques. These are the tools for interaction.
Like adopting a neutral attitude. The example, patient says, the food is poisoned. Nurse responds, that must be very unsettling for you. Validating the feeling without agreeing with the delusion.
Right, or encouraging comparison. Patient says, I stayed up all night. Nurse asks, you were having difficulty sleeping. Clarifying.
Exploring things further. Tell me more about what led you here.
And basic but vital, active listening. Minimize distractions. Face the patient. Really be present.
These techniques fit into the phases of the therapeutic nurse-patient relationship.
Yep. 4 phases. 1. Pre-interaction nurse prepares, gathers info. 2. Orientation, build trust, set goals.
3. Working phase. This is where the main work happens. Promoting change, managing tricky dynamics.
Like transference and countertransference. And phase 4. Termination, evaluating progress, ending the relationship therapeutically.
Let's unpack transference. That's the patient relating the nurse to someone from their past.
Exactly. Like seeing the nurse as a father figure because of their own father-son relationship. The note says, work with patient to sort out past.
Okay. And countertransference is the other way around. The nurse's inappropriate reaction.
Yes. The nurse developing personal feelings, maybe accepting inappropriate gifts. The note is clear. Do not accept generous gifts.
It's all about maintaining those professional boundaries for safety and communication. Empathy is key, though, right? This must be very frightening for you.
Absolutely. And the environment matters too. Milieu therapy is mentioned.
Creating a structured, supportive setting that's inherently therapeutic.
Mm-hmm. And from the therapeutic setting, we move into the critical, legal, and safety rules.
Yeah, this stuff is serious. Restraints and seclusion. Physical straps or confining someone.
The notes are emphatic, never used as punishment, only for immediate safety risks when nothing else works.
Try medical restraints first. Get them off ASTP. Seclusion 2, discontinue ASAP. Ensure comfort and safety, minimal furniture.
And doing this without a proper order is false imprisonment.
Right. There are strict time limits for evaluating someone in restraints, too.
Adults every 4 hours, children every 2, young children every hour.
Another absolute.
Yeah.
Suspected child or elder abuse.
You must report it, period. Not reporting is a criminal ACT.
And you have to explore potential abuse, even if the person has hallucinations or delusions. You can't just dismiss it.
Very important point. Then, informed consent. Respecting autonomy.
Provide risks, benefits, options. Respect their choice. But there are exceptions.
Yes. If someone is mentally incompetent, if refusing treatment puts their life in immediate danger, or if they're a child.
Okay. And involuntary commitment.
Must be court-issued. 2 main grounds listed. Immediate danger to self or others. Suicidal, homicidal, or unable to care for basic needs, gravely disabled.
The notes also list slightly different reasons for involuntary patient commitment, also court-issued.
Right, like repeated serious mental health crises, risk of bad outcomes like homelessness or violence, or consistent non-compliance leading to relapse.
This section really highlights the weight of responsibility in mental health care. Okay, broadening the lens one last time.
The notes touch on wider context, social determinants of health.
Things like poverty, education, neighborhood safety, access to care, they all massively impact health.
Definitely. There's also Jahoda's 6 indicators of mental health, a positive view.
Positive self-attitude, growth, integration, autonomy, accurate reality perception, environmental mastery. Signs of thriving.
Maslow's hierarchy has listed 2 basic needs first.
And the stages of grief. Denial, anger, bargaining, depression. Important for understanding loss.
And finally, just reinforcing the core definitions. Mental health as overall well-being versus mental illness as a condition affecting thoughts, feelings, mood, or behavior.
Wow. We really did cover a huge amount of ground there.
We did. From anxiety's impact and coping mechanisms, through brain chemistry and meds, therapeutic interactions, safety rules, and those bigger societal factors.
It really shows how interconnected everything is. You can't just look at one piece. You need the biological, the psychological, the social, the legal, all of it. Hopefully digging into these notes gives you a more structured way to think about this complex field.
So thinking about all these different elements we've touched on, the biology, the coping, the social side, the rules, what aspect for you stands out as maybe the most critical piece in supporting someone's mental well-being, and why?
Something to definitely mull over. There's always more to explore, but hopefully this deep dive into the source material has given you a solid and thought-provoking foundation.